My name is Robert Greenwald. I'm a clinical professor of law here at the law school, and I'm the faculty director of its Center for Health Law and Policy Innovation. I have the pleasure of introducing a longtime friend and colleague, Larry Levitt, this afternoon. For those of you who don't know Larry, let me start by saying that he has a number of different titles at the Kaiser Family Foundation. He is a chief among the titles, or a senior vice president for special initiatives, senior advisor to the president of the foundation, co-executive director of the program for the study of health reform and private insurance, and I think he has a few other titles at the Kaiser Family Foundation. But despite the numerous titles that he has there, they don't really accurately describe who Larry is or what he does. In short, Larry is truly one of the go-to people on health reform in our country. I mean, governments turn to him, media turn to him, advocates turn to him, and the like. I mean, during the past several months, for those of you who have been following repeal and replace and reading any media source, you have been seeing Larry quoted on a regular basis. I mean, he is just a very well-trusted voice on all things healthcare, which is, again, why you see him from the New York Times to Fox News. And there's Larry. Now, our timing of our talk probably could not have been better. About a week ago, we were on the phone and said, okay, you can't plan anything because we don't know what the conversation on the future of healthcare reform, what direction we're going in, is going to look like. Thankfully, with GrahamCassidy behind us and the Senate parliamentarians ruling that under reconciliation, September 30th was the final date. It is now, October 3rd. We can at least rest assured for now that the efforts to repeal and replace the Affordable Care Act are behind us, and begin to take a little bit of a breath and start to talk about, so where do we go from here? So that's really what Larry's here for, and thrilled to have him. Just a few other comments. One, I want to thank Petrie-Flom Center and also the Health Law Society, who, in addition to my Center for Health Law and Policy Innovation, are sponsoring this event today. Also, we're live streaming today's event and live tweeting, so we encourage you to follow along and add to the conversation on Twitter. You can make sure to tag Larry Levitt at Larry_Levitt, or Petrie-Flom Center at Petrie-Flom, or the Center for Health Law and Policy Innovation at Harvard.Chilpy. So my pleasure to introduce Larry Levitt.
Thanks, Robert. What Robert didn't mention about my resume was that I pretty much made a career out of failed healthcare reform plans, from here in Massachusetts to California to the Clinton health plan. I was actually out of the country during the Obamacare debate, so that's obviously why it passed. But I was here during the repeal and replace debate, so I am confident to say I am clearly not the common denominator in failed reform plans. So I want to keep that, unless there's any opposition, I want to keep this informal. So please don't scream out questions, but feel free to raise your hands during. I can talk forever, but I don't need to talk forever. So if anyone's got questions, comments, alternative views, please feel free to jump in as I go along. So I want to, which direction do I click? No? Okay. Will this work? Huh. Oh, there we go. Okay. We'll do this. So I want to spend a little time stepping backwards before we step forwards. Oh, you want to? Okay. Okay. Talk a little bit about what the ACA has accomplished. I mean, we sort of forget that it's actually done some good things because it's been so controversial. And I think the most important place to start is what's happened to the number of uninsured. The uninsured rate is at its lowest level ever under the ACA, dating back to the days when Richard Nixon was president, when almost none of you were born. The ACA, I mean, that was the main job that the Affordable Care Act had, was to increase the number of people with insurance coverage, and it has done that, leading to 20 million more people insured. I would say the second most important chart is the 27% of people who have pre-existing conditions. These are people who were subject to denial of insurance, increased premiums, riders or exclusions from coverage in the individual insurance market before the ACA. These are things ranging from AIDS and cerebral palsy to substance abuse, diabetes, pregnancy, obesity. I was amazed when I was tweeting out this study when we first did it, and I was showing a table from an insurance company underwriting manual that listed the pre-existing conditions that led to exclusion, and one of the pre-existing conditions was height and weight. Now, what they meant was, height relative to your weight, but the number of responses saying, yes, I have height and weight. Look, I could have been excluded from insurance. My old friend Atul Gawande, when we did this study late last year, anticipating the repeal and replace debate, turned it into a hashtag, the 27%, and gave it a lot more attention, and talked about his son as well. I mean, and that's kind of really, as we saw in the debate, I mean, this issue of pre-existing conditions was extremely personal for people, and I think became quite powerful. Now, I think one of the broadest benefits of the ACA, two broadest benefits, were providing coverage to.
We're having some technical
okay.
Okay.
Providing coverage to dependents, young adults up to age 26, which provided coverage to millions of young adults, and providing contraceptive coverage for free, which affected many more people. Now, I don't know if there are any economists in the room, but they'll surely jump in and say nothing is free. Obviously, someone paid for this contraceptive coverage. But from the perspective of women, the coverage was available with no out-of-pocket costs in almost all insurance plans, and it had a dramatic effect. Out-of-pocket costs for women for contraceptives dropped dramatically. Unfortunately, the contraceptives didn't come with a stamp that said brought to you by Obamacare, but I think many people realized that was the case. Now, at the other end of the spectrum, affecting fewer people, but in a very dramatic way, was the prohibition on lifetime and annual limits on insurance. And I'm not sure people understand how prevalent these were. In employer plans, 59% of workers had a lifetime limit on their coverage, $1 million, $2 million, $3 million coverage, $3 million. Very few people would ever hit this limit, but if you were in that small group of unfortunate people who did, this was a very big deal. And the ACA prohibited lifetime and annual limits. Now, as nice as all these things were, you would think the ACA was incredibly popular, which of course it was not. And we've been tracking the people's views about the Affordable Care Act back to its passage, and in fact, pre-passage during the debate. And it kind of goes up, it kind of goes down. But generally, the public, the American people, have just been tremendously split on this law, largely along partisan lines. Interestingly, the time that the ACA became the most popular was in the last year when we were debating its possible demise. And the ACA, you could see here in August, reached its peak of popularity at 52% of adults. And at the same time, Republican replacement plans were incredibly unpopular. So moving on to the repeal and replace debate.
Come on in.
Yeah. The president has been saying throughout this year that the ACA is either collapsing, exploding, or imploding. How something can explode and implode at the same time, I don't know. But the president has been asserting that, and it may surprise some of you to know that it, in fact, has not been true. First look, I mean, the ACA has two main parts, the Medicaid expansion and the changes in the insurance market and the creation of health insurance marketplaces. The Medicaid part, as my friend Emma Sando will certainly point out, has not at all been collapsing or failing. or exploding or imploding. The Medicaid expansion has covered over 12 million newly eligible poor and low-income adults, and by all accounts is working just fine. The big exception are the 19 states that chose not to expand Medicaid when it was made voluntary by the Supreme Court back in 2012. Now, the insurance marketplaces are a somewhat more complicated story. If you look at premiums in the marketplaces, these are benchmark premiums for a mid-level silver plan. These premiums initially came in quite low, much lower initially than the Congressional Budget Office had projected. But they did jump this year. They jumped quite a bit this year, from $299 for a 40-year-old on average to $361. And really kind of the experience of more sick people signing up than expected and fewer healthy people signing up than expected kind of caught up, and insurers finally realized that their premiums were running behind their costs and increased premiums substantially. I think all expectations are that this was a kind of one-time market correction, but a lot has happened over the course of the year that may change that. Now, important to remember that most people who are in ACA insurance plans in the individual insurance market are shielded from these premium increases. The premium subsidies that are available to low and middle income people rise along with the premiums. So if you're eligible for one of those subsidies, if your income is below 4 times the poverty level, then you're shielded from the effect of the premium increases. Now, of course, the government cost for those subsidies has been rising as the premiums have gone up. And there are people, self-employed people, early retirees, buying their own insurance outside the marketplaces who feel the full brunt of these increases. And that's certainly been a problem. Now, if we look at enrollment, enrollment increased dramatically following the meltdown of healthcare.gov in the first year, and rose to 12.7 million in 2016. There were, enrollment in this last open enrollment period, which concluded at the end of January, did drop somewhat. There was, it was interesting to look a little more deeply at what happened. Before President Trump took office, enrollment was actually running ahead of the previous year, ahead of 2015. But in those last couple weeks of open enrollment, it dropped. And there are theories, which I think are fairly compelling, that a couple things happened. One is this perception that as President Trump took power, the law was somehow immediately repealed. The individual mandate was somehow not in effect anymore, and that affected people's behavior. Certainly also the president was talking about the law failing, collapsing, exploding, which might have discouraged some people from signing up. And in the last couple weeks of open enrollment, the president pulled back on outreach and advertising for the law, which certainly may have had an effect as well. So enrollment dropped somewhat, but with over 12 million people signed up during open enrollment, it's hardly a picture of a law collapsing. Now, if you look at insurer participation, there has been a decline in the number of insurers participating in the marketplaces, in the number of counties, particularly rural counties that have only one choice, one insurer. There have not been any counties with no insurers at all, and that looks like it's going to be the case in 2018 as well. And I think there's a couple things. One is, some insurers have had some difficulty making money, particularly large national commercial insurers like United and Aetna and Cigna and Humana. And these marketplaces have turned out to be much more price competitive than people expected. And a lot of these established insurers just couldn't compete, get their premiums down low enough to compete and earn a profit at the same time. So regional plans have dominated the marketplaces, insurers that have traditionally served Medicaid beneficiaries, Blue Cross Blue Shield plans, which have always been active in the individual insurance market. So not a positive story that there's emerged as less choice, but again, hardly a collapse. And if you look at what's happened to insurer finances over this same period, insurers certainly did have difficulty in the first several years of the law in 2014, 15, 16, earning a profit. Many, in fact, lost money, and the industry as a whole lost money in the individual insurance market, even though they were making money overall and doing plenty well. But things changed dramatically in 2017. As insurers made this one-time correction and increased premiums, gross profit margins have increased dramatically this year, and that continues to be the case. Now, interestingly, if you ask marketplace enrollees how they feel about the law and whether they feel they benefited from the law, most feel they have. There's some kind of predictable predictors, like whether you received a subsidy. If you receive a subsidy, you feel better about the law than if you didn't. If you have a high deductible, you feel worse about the law than if you have a low deductible. But an interesting indication of how partisan this law is, if you ask marketplace enrollees, so these are all people who are enrolled in an ACA plan, the number one predictor of whether they think the law was a good thing or a bad thing is whether they were a Democrat or a Republican. Not what their income was, not what kind of insurance they were in. Identical people, just one's a Democrat, one's a Republican, feel dramatically differently about the law. So moving ahead to January and the repeal and replace debate. Some of you may have forgotten, but this kind of kicked off mid-January with the president promising that a replacement for the ACA would provide insurance for everybody. It would be much less expensive, and it would have much lower deductibles. That turned out to be kind of hard to do and kind of not true. It is complicated. Robert, you're falling down on your job. It is complicated. It is, in fact, an unbelievably complex subject. This was just 6 weeks later, so it was a very quick education for the president, as it turned out. So let me talk about a few of the key themes that emerged during the repeal and replace debate. First was the process, which I think in many ways drove the outcome. As I think many of you probably know, the Republicans in Congress decided to use the budget reconciliation process to pass to repeal and partially replace the ACA. That process turned out to be both a blessing and a curse. In the end, probably a curse. It had the advantage of allowing Republicans to pass a bill with a simple majority without needing 60 votes, and therefore Democrats in the Senate. But it also limited what could be done, because there are certain limitations in the budget reconciliation process in terms of what kinds of provisions can be enacted. I personally think that Republican leadership made a tactical mistake by even promising that they could use this process to repeal and replace the ACA. I think Mitch McConnell and Paul Ryan would be sitting much happier right now if they had said, look, we need 60 votes in the Senate, we need Democrats, this is going to be really hard, we'll see where it goes. But they made promises that they ended up couldn't in the end fulfill. I think the belief was that this would be very simple. Republicans had passed a repeal and replace bill that President Obama had vetoed, and that was kind of a trial run. And that bill essentially would have repealed the guts of the ACA, but with kind of a delayed effective date, with the expectation being that a replacement would be figured out in the meantime. But that kind of so-called repeal and delay strategy became very controversial as soon as it was proposed in January or even December. And a lot of opposition emerged, a lot of concerns that the market, legitimate concerns that the market would destabilize immediately because the individual mandate was repealed, in fact, retroactively. So very quickly, that became a non-starter. There was also, as part of this, no so-called regular order, no committee hearings to speak of, no markups. Much of this was done behind closed doors, and turns out there are at least a couple senators who actually still believe in the legislative process as it, we learned it in Schoolhouse Rock on TV, and that turned out to be a problem. So some of the key themes, I mean, there were a lot of bills during this year, and I will certainly not go through all those bills, although you can read summaries of them on our website if you want. But there were a number of key themes that were present in virtually every single one of these bills. One was eliminating funding for Planned Parenthood. I believe that was in every single bill. Interestingly, the bills only repealed Medicaid funding for Planned Parenthood for 1 year. Because it turns out if you end, Congressional Budget Office anyway, believes that if you end funding for Planned Parenthood, more people will get pregnant. That will increase costs over time, and so that's something that you couldn't do under the budget rules. So it was just a 1-year elimination of funding. Repeal of the individual and employer mandates was a constant in the debate. Phasing out the Medicaid expansion, which turned out to be one of the most controversial parts, was in every bill. Taking the premium subsidies under the Affordable Care Act and shifting them from older, lower-income people to younger, higher-income people, and shifting them from high-cost areas to low-cost areas. And just to give you one example, under the bill that the House actually passed, a typical 64-year-old making $26,000 would have gone from paying an after-subsidy premium for a mid-level plan of $1,700 in 2026 under the ACA to $13,600, or over half their income under the House-passed bill. Certainly a lot of talk of scaling back regulation and consumer protections, capping federal spending on Medicaid. All of Medicaid was a constant. And what may have been the motivation all along, repealing many or all of the ACA's tax increases. So this all culminated in the last few weeks with what I think was the most radical of any of the plans that Congress debated, and that was the GrahamCassidy, Heller-Johnson plan, which really in many ways went further than any of the other plans. It repealed the individual employer mandates like the others. It actually repealed the Medicaid expansion and the premium subsidies entirely starting in 2020. And it created a new block grant for states, turning over $1 trillion to states in a way that I never would have thought a Congress could ever do, with very few strings attached, dramatic redistributions in money from state to state, and an across-the-board cut as well. And then it went even further and gave states tremendous flexibility to alter the consumer protections and insurance rules in the ACA, particularly the essential benefits, the required benefits that insurers had to provide, community rating, which prohibited insurers from charging people with pre-existing conditions more than those who are healthy, the cap on out-of-pocket costs for patients, the loss ratio, which capped the administrative costs and profit overhead for insurers. So tremendous flexibility to states. And of course, like all the other bills, it capped federal spending for Medicaid as well. So just to give you a little sense, and there were a number of studies that came out in the last few weeks of how this would affect states. This was one we did, which actually made very conservative assumptions. To give you a sense of how much money was moved around, California would have lost $62 billion over the 2020 to 2026 period. Texas would have gained $28 billion. Florida lost $10 billion. But of course, all anyone cared about was what happened to Alaska and Senator Murkowski. And our estimate was that they would lose about $300 million, which doesn't sound like very much. Yeah?
Most of the states that refused the Medicaid expansion. So the fact that they didn't take that federal money, is that what makes these federal monies more beneficial to them?
Yeah, no, exactly. There were essentially what it did was it moved towards a formula where states got money based on the number of low-income residents in the state. So it was irrespective of the cost of coverage in the state or whether the state had taken the Medicaid expansion or how successful the state had been at signing people up in the marketplace, because it took the Medicaid expansion money and the premium subsidy money. So what that meant is states that had expanded Medicaid or signed a lot of people up lost money. States that had not got a windfall. And there was this perception that this was somehow, that it was unfair that Texas, was losing money because California was getting lots of money because it expanded Medicaid. Texas, Mississippi were not. But of course, there was nothing stopping Texas and Mississippi from expanding Medicaid and getting all the same money that California was getting. And that's still the case. So let me go through some reasons why I think repeal and replace failed, at least for now. One, as we talked about, it is complicated. Health reform is almost never a political winner. I've devoted my career to healthcare, mostly unsuccessfully, as I said. But I can't tell you how many politicians I have said when they say, what should I do if I get in office? And I say, well, don't do healthcare. Education, criminal justice, just don't touch healthcare because it's not likely to work out so well for you. And that turned out to be the case here as well. I talked about the process, and I think it was both the process for process sake. So some, like Senator McCain, who has been in the Senate quite a while, at least if we can take him at his word and say that it was not a regular order process, and he was uncomfortable with that. But it also mattered for the substance. I don't know how many of you have sat through congressional hearings. They're not always the most scintillating, but they actually do matter. The members get educated during these hearings. Issues get surfaced, and there's kind of a reason for the process, and you end up with a more solid bill in the end. These bills were just honestly a mess. Forget whether you agreed with it or didn't agree with it, but if GrahamCassidy had actually become law, there were just so many problems with it, and that's because it really didn't go through any kind of structured process. I think Republicans didn't really come into this with a coherent set of policy aims, beyond get rid of Obamacare. So it turned out to be hard to construct a replacement plan as a result. And that's a big contrast to what Democrats did in 2009. There were a number of years leading up to 2009, 2010, where Democrats had kind of coalesced around an approach that eventually became the Affordable Care Act. And it wasn't perfect, obviously, but there was a consensus among Democrats that that was the right way to go.
In terms of not a clear set of policy aims, so I don't think Obama was particularly upfront about the policy aims either, in that it was very much sold as a program for the middle class, where the reality is a lot of the resources, it was a cash transfer from the wealthy to the poor. There's all the taxes that are paid for Obamacare are basically taxing wealthy Americans, and paid for the Medicaid expansion, which gave health care for the first time to millions of poor people. I think their coherent policy aim was to eliminate those taxes and give tax cuts back to the rich. And so the real problem was that when you put that up against what they said they were trying to accomplish, which was health care for everybody at a lower cost, which they couldn't really come through on, but really underneath it all, their policy aims were ones that didn't sell to the American public, but they had them.
No, let me say it a little differently. So I think Republicans expected to do this repeal and delay strategy, where they could repeal the taxes, repeal the mandates, and not figure out what they were going to replace it with, and they were okay with that. When that became an unacceptable policy, they were a little stuck. And I think, I think the aims of eliminating the mandates, rolling back regulation, repealing the taxes, they were very clear about that. But when all of a sudden they were on the hot seat and had to figure out what they were going to replace it with, that became more problematic. And it was remarkable. It was, every time an issue became controversial, whether it was taking away protections from people with pre-existing conditions, eliminating the Medicaid expansion, what would happen with deductibles. There was sort of this oh crap moment that no, we don't want to. We want to lower deductibles. We don't want to increase deductibles. We're going to protect people with pre-existing conditions, and it didn't. It didn't match in any case the bills that were actually being produced. But there was there was an inability to kind of construct a coherent, positive policy. I think there was also, it sounds easy that, okay, they just had to get Republican votes. They didn't have to get Democratic votes because of budget reconciliation, the budget reconciliation process. But there was still sort of this Goldilocks syndrome problem, where could you find a bill that would please both Rand Paul and Susan Collins at the same time? That was not too conservative, didn't repeal taxes too much, didn't cut spending too much, but did it just enough to please conservatives, and that turned out not to be quite possible. I think the power of pre-existing conditions and the Medicaid expansion emerged very clearly in this debate, and I think will endure in any future debates. Who knew we would have a Kimmel test? Who knew we'd have a Kimmel test that Senator Cassidy himself coined and then couldn't pass? But these are, these became extremely personal. Were very personal for people, and you saw it coming out in town hall meetings, and I think were very significant wedge issues during the debate. Also political mobilization that occurred over the last year. I think many people believed that this was all over once the election happened. I was quoted in the Washington Post saying the Affordable Care Act was toast, and got a lot of angry comments as a result. I always thought there was like a 10% chance that the ACA might not be repealed this year. And a lot of people didn't even give it that much of a chance. But there was, and I will say, look, back in January, this mobilization did not appear to be happening. Hospitals didn't appear to be organizing. Grassroots groups didn't appear to be. And then all of a sudden, it really happened. And it grew as the debate went on. And then finally, I think Joni Mitchell had it right that you don't know what you got till it's gone, and that became very clear during this debate. So what might come next? This is definitely not over. It is entirely possible that we will return to a repeal and replace debate. I don't think it's going to happen immediately in the near future. It could happen next year. It could happen in a lame duck session after the 2018 election. But honestly, I threw away my crystal ball months ago, so don't believe me anyway, if it actually does happen. But this debate, I think, is coming back in some form. Certainly, we are going to see administrative actions and waivers for states from the Trump administration, and I'll talk about that. I think it's possible there will be bipartisan legislation to help stabilize the insurance market, and I'll talk about that. But first, I think the first thing up is open enrollment, which starts November 1st, and could, depending on how it goes, determine a lot about the future of the ACA. So just looking back at how the Trump administration has been running the marketplaces. And it's really been kind of remarkable. I mean, elections, we all know elections matter. We all know policy direction changes with a change in administration. But I have trouble thinking of examples, anything like how the Trump administration has approached the insurance marketplaces. I understand it's awkward. I mean, you're an administration that comes in vowing to repeal it all, but you are actually responsible for running the program. But the way the administration has run the program is really quite remarkable. It started the night of the inauguration with an executive order from the president calling on agencies to, it used all kinds, it used every buzzword you could imagine: waive, defer, exempt, talked about doing anything that would avoid imposing a fiscal burden on states, a penalty, a regulatory burden, et cetera. Now, this executive order didn't actually, it used all these fancy buzzwords. It didn't actually do anything tangible, but it sort of set the tone for how the administration would approach the ACA. This was actually followed by promulgation of a regulation to help stabilize the insurance market, sort of starting this odd period of very mixed signals. Arguably Some people argue that parts of that regulation were destabilizing, but mostly the intent was to stabilize. It kind of included the insurance industry's entire wish list of things to do. Next up, the administration announced that it was not going ahead with some planned increase in enforcement of the individual mandate, but didn't really, hasn't yet rolled back enforcement of the mandate. Potentially most dramatic, just happened in the last couple weeks actually, was dramatic cuts to outreach and consumer assistance for the next open enrollment period. A 41% cut to funding for navigators, which are community groups that help people enroll in the marketplaces and in Medicaid. A 90% cut to advertising during open enrollment. A direction to regional offices not to participate in community-based enrollment events. And this matters a lot because there's an enormous churn in this market. People rely on the individual market when they have nothing else to rely on. So as people lose jobs, gain jobs, get married, have lower income, have their incomes lowered, and become eligible for Medicaid, millions of people kind of cycle in and out of this market each year. So every open enrollment period, you have to sign up millions of new people just to keep enrollment steady. So if there's very little assistance, very little outreach, it's possible those millions of new people won't sign up. And it's very likely that the people who won't sign up will be healthier than average. And that will lead to a deterioration in the risk pool and then higher premiums over time. And then finally, the president has consistently threatened to eliminate cost-sharing subsidy payments to insurers. So these are payments to insurers that compensate them for the fact that they have to provide lower deductibles and copays to lower-income people, which cost upwards of $7 or $8 billion a year. And these have been subject of a lawsuit, and the president has consistently threatened to cut off those payments. And if you look at what effect that would have, we did an estimate a few months back that if these payments were cut off, insurers on average would have to raise premiums by 19% on mid-level silver plans to make up for the difference. And that's exactly what we're seeing. Insurers being unsure of whether these payments will continue. When they had to finalize their rates in the last couple weeks, many of them have raised premiums in the range of 20% or even more in some cases. And it sets up a kind of interesting couple scenarios for next year. If the president does end the payments or the courts end up ruling that they have to stop and Congress doesn't appropriate them, then insurers, will kind of be sitting okay. Most of them have raised their premiums, and they'll be that'll provide them with enough revenue to offset the loss. If the payments continue, insurers will actually be sitting pretty with much higher premiums and still getting the cost-sharing payments and could actually be earning record profits in this market next year. So we'll see what happens. But in the meantime, it kind of creates this environment of chaos, confusion, and the president will certainly be pointing to all these premium increases when they become public as a sign that the law is failing. Now interesting, our polling has shown consistently that when we ask people kind of who owns any of these problems going forward in the ACA market, is it President Obama and Democrats because they passed the law, or President Trump and Republicans in Congress because they're now in charge of the government? And the public consistently says, substantial majority, that it's President Trump and Republicans in Congress. And I would think if this were a conventional administration, they would want to avoid problems, avoid chaos, and avoid blame for these kinds of problems, especially going into a midterm election. But obviously, this is not a conventional administration, and instead one that seems to thrive on chaos. So I'm not sure the standard rules apply. So let me talk a little bit about this effort in the Senate to pass a bipartisan stabilization bill. And this has been led by Senator Alexander and Senator Murray in the Senate Help Committee. I give it a relatively small chance of success, but even the fact that there are bipartisan talks going on surrounding the Affordable Care Act is pretty remarkable and may help calm the waters to some extent going forward. It's a pretty modest package that's being talked about. It would guarantee these cost-sharing subsidy payments potentially for 2 years. It would allow insurers to, this is all reportedly, allow insurers to offer a kind of more catastrophic, higher deductible plan. So rather than a bronze plan, which is the minimum they can offer now, it would be a copper plan. Still shiny, but it would offer modestly more flexibility for states under the waiver process in the Affordable Care Act. And nothing like what was in GrahamCassidy, but I think something for Republicans to point to that they're kind of moving in a direction they want to move. And there have been discussions of what's known as a reinsurance program, so a program that would help pay for high-cost patients and allow insurers to lower premiums as a result. That actually costs money, so that's probably unlikely to happen, but certainly could have a significant effect. Now, if you ask the public, what do they want? I mean, generally, I will say this is not one of our fair polling questions. Generally, people, want Congress to get along. They want bipartisan action, and that's certainly true here. Although there's still a big partisan split. I mean, Republicans generally still want Congress to work on a repeal and replace plan and not cooperate with Democrats too much. So now over the last couple weeks, there's started to be talk of some administrative action the Trump administration may take. There are a couple obvious ones, certainly ending these cost-sharing subsidy payments, known as CSRs, weakening enforcement of the individual mandate, and I would certainly not be surprised to see a midnight before open enrollment announcement from the Trump administration saying they are doing these things to try to discourage people from signing up. But there's also been this growing talk of a potential executive order, an additional executive order. Senator Rand Paul said he's been talking to the administration. The president actually, as he was getting on the plane the other day, had this somewhat rambling statement that you see here. And it's kind of all speculation so far about what this might be. So we don't have any clear idea of what it might be. It gets very wonky fast. It involves ERISA, and anything that involves ERISA, the federal ERISA law, gets complicated extremely fast. But at least based on Senator Paul's statements, the president's statements, what it might be is using, kind of stretching the envelope of executive power under ERISA, possibly to the point of breaking, that would allow a parallel market for insurance, that would allow insurers to offer products in the individual market and to small businesses that didn't comply with the ACA's rules, and potentially allowing those products to be sold across state lines, so preempting state authority to stop them or control them. And that could be quite damaging to the insurance market and destabilizing. It would allow these parallel plans that would deny access to people with pre-existing conditions, charge them higher premiums, offer skinnier benefits that attract healthier people. So essentially allow a parallel market to cherry-pick healthy people and leave the ACA market with sicker people and therefore much higher premiums and probably result in its collapse over time. So, this may be all speculation. It may not happen, but there are at least signs that this may happen. And I think certainly now that the congressional debate is at least stalled, we're going to see a lot more waivers, both Section 1332 waivers under the Affordable Care Act and 1115, so-called 1115 waivers under Medicaid. And I would expect, and the administration has certainly given every sign that it will give states greater flexibility, although recently has sent some mixed signals. And it's unclear whether it's just administrative lack of administrative competence or actually substantive signals. But the administration was encouraging states to submit these waivers and recently kind of ran out the clock on a waiver proposal from Oklahoma and didn't it died. And then a waiver proposal for Minnesota gave a very kind of mixed decision that made it very hard for Minnesota to do what it was proposing to do. So, it's unclear exactly how this will all play out. So let me just conclude with a topic that's always dangerous for me, single-payer healthcare. And I will invite lots of angry tweets by saying I don't think it's going to happen soon. But it's clear it's going to play a major role among Democrats in the 2018 and 2020 elections, and could become something of a progressive litmus test for Democratic candidates. I think it's important. I mean, single payer has become this rallying cry, but it's important to start to unpack, what the aims of single payer advocates are, and whether a single payer health plan is necessary to achieve those aims, or whether you even agree with all those aims. I think most prominent is universal coverage. And there's no question that a single payer plan, which is tax financed and therefore everyone is eligible automatically, can achieve universal coverage much more easily than a plan like the Affordable Care Act. And I think the structure of the ACA makes it very hard to ever get to full universal coverage. The single payer plans recently have moved to eliminate out-of-pocket spending on health care. Deductibles have become the new boogeyman, I guess. No one wants higher deductibles, although everyone really does secretly want higher deductibles, or at least every plan. But recent single-payer plans have entirely eliminated patient out-of-pocket costs. Another aim of single-payer plans is to reduce health spending through lower prices, less administrative overhead. Although, one difficulty is that if you eliminate patient out-of-pocket costs, that's actually going to boost health spending, so it kind of works against this aim. And it's never been clear to me in our political system what would happen to healthcare prices under a single-payer plan. In other countries with more governments with greater policy power, certainly healthcare prices are lower, substantially lower. But with the power of the health industry in this country and weak campaign finance laws, I don't know what would happen to healthcare prices under a single-payer plan. Certainly a desire to eliminate or reduce profit in healthcare. And potentially the most powerful and most disruptive part of a single-payer plan is how it redistributes the financing of healthcare from premiums and out-of-pocket costs to progressive taxes, which means there are a lot of winners, lower-income people, but a lot of losers, higher-income people as well. So we've been starting to poll a bit on single payer, and there's been a modest increase in support for single payer, particularly since Senator Sanders made it a big issue during the campaign. But there's still a tremendous partisan split between Democrats and Republicans on this issue. Support is still. Next, Robert. He was immersed in that chart.
It's actually fascinating about independent.
Yeah.
Thinking that, wow, it's 58%, but I get that there's a high percent of somewhat favor, which can go either way when
exactly.
the going gets tough.
Exactly.
That's what I was
and really, when we poll and other people poll, it's natural to split Democrats, Republicans, Independents. But there are no real true independents in this country anymore. I mean, there's kind of Democratic-leaning independents and Republican-leaning independents, and they basically behave like their compatriots. So single payer, I mean, there's this kind of symbolic support for it, but still, the debate hasn't really been engaged, and the support is frankly soft when you start pressing people on issues like. You tell them that it would mean people have to pay higher taxes, support drops significantly, or it would give government more control over healthcare, support drops. It would eliminate the role of employers in healthcare, support drops. And you see some of that on the other side as well, but more modest, that opponents, if you tell them that it would mean universal coverage, everyone has health insurance, it would reduce administrative costs, you see some drop in opposition. And then finally, I'll end here and take any questions. If you ask Democrats and Republicans, what the government should do now, basically still speaking an entirely different language on healthcare. Democrats think government should either improve the ACA, although a substantial percentage, almost as many, think Congress should try to pass a national healthcare plan. Republicans think that, a small percentage think that the ACA should be improved, but still believe that the ACA should be repealed and replaced. So, it's, and that I think is in some sense the value of this potential bipartisan effort in Congress, that it starts to create a bridge, starts to get what Republicans would be giving up in that is at least some appearance that there's an investment in making the ACA current law work. Democrats would, of course, be giving up some things as well, like greater flexibility for states. But just the mere fact of having parties start to talk to each other on health care could alter the shape of the debate going forward. So I'd be happy to answer any questions, take comments.
I'm just going to, hold on a second, I'm just going to use the,
Okay.
the capture.
I had two sort of related quick questions. One about 2019, really, and about 2018. Do you think that the Alexander and Murray bill is essential for sort of 2019 to come together? You said that, the insurers are already raising some of their rates late year for 2018 to sort of cover themselves in case the CSR payments go away. A lot of the plans that came in to cover the Bald County seemed like they were sort of making these last-minute deals with governors. And do you think that everything's going to collapse for 2019, or that everyone's going to rush back in after they see how much money everybody makes?
I would say neither. First, this Alexander Murray plan is too late for 2018. Everything, the insurers have largely already signed contracts. There's actually a possibility that the president could be a hero and, say he's going to commit to paying the cost-sharing subsidy payments, and he's going to delay the start of open enrollment and allow insurers to refile their premiums and file for 20% decreases, and he could, stand up and claim credit for that. I don't think that's likely to happen, but it's at least a possibility. I think to me the greater importance of the Alexander Murray effort is symbolic, because I think the insurers that are willing to stay in the market under these circumstances, have figured out a way to deal with the possibility that these cost-sharing subsidy payments might end, and would probably be okay. I think the bigger risk is kind of what if the president ended the payments later this year or sometime next year, kind of what the tone of that is. So if I'm an insurer and I hear the president say, I'm going to do everything to make this law fail, I'm going to end these payments, I actually think weakening enforcement of the individual mandate would be an even bigger deal at this point. So if I'm an insurer and I just see the president showing no interest in making this law work, I'm less likely to stick around. But the cost-sharing subsidy payments in and of themselves are not as big a deal.
Thank you. And then, sorry, one other question was about on the Medicaid side. So now that sort of the sort of capping and block granting schemes have sort of fallen away, do you see some moderate Republican states expanding this year? I think the countervailing thing that I would see is a state like Massachusetts, where they're struggling to pay for their own expansion. I'm just curious your thoughts on where you think that's going.
Well, first of all, I don't think the capping has gone away, and I think could even emerge in the tax debate as a way of helping to pay for tax cuts. Although that would be terrible optics, I would think, for Republicans, but certainly possible. I do think ultimately more states will expand if the status quo stays put. I think next year will be hard in an election year, but after the election, it's just a lot of money for states to turn their backs on, and they have an administration that will grant them, waivers to allow them to put a more conservative stamp on it. So I would absolutely see more states expanding. And I think it's highly likely that the administration will allow states to expand, rather than having to expand all the way up to 138% of poverty, expand only up to 100% of poverty, people above that level getting insurance in the marketplaces. And it's even possible that some states that have already expanded will actually slide back. This will cost the federal government a fortune, but people will have health insurance. Oh. You wearing your Fitbit? You're definitely getting your steps.
Thank you. Wonderful talk for sharing. Actually, I rushed all the way from the Harvard Medical School here. And, one impression is that if you look into the figures, our total, health expenditure, is estimated to be, around, $4 billion. And if you divide by each person in the United States, about $10,000 per person. And, if you use the simple, strategy of, say, go where the money go, and we find that the most expensive piece of the pie chart is the hospital care, which accounts for 1/3 of all the $1 trillion. And the next come to the 20% of the physician and clinical service. And the list, well, not list, but the third tier is the medication, 10%. Could we do something using, say, industry engineering optimization process to restructure the system? Actually, in the old day, people do comparative effectiveness, longitudinal study at our other campus, the School of Public Health, and also by the federal government. And they try to compare A versus B, which process can, more efficient, cost less, rather than, actually, if you, reshuffling, almost like music chair, nothing changed, and the expenses are there. So I wonder how you look into, the mechanism rather than the policy, so we may do a better job of service.
Thanks. Well, I'll give a optimistic answer and then a pessimistic answer to that, so then I'm covered. The optimistic answer, and my old friend David Cutler, who's here at Harvard in the economics department, I think says this really well. That we're kind of always looking for this magic bullet to deal with healthcare costs, and there's often a debate about things we do in healthcare to get costs down that are sort of one-time changes but don't deal with the rate of growth. And I think David says it very well that there isn't a magic bullet, that it's a matter of doing a whole bunch of things that produce small changes but add up to big changes overall, and having to do them constantly and keep adding to them every year. And that's how you reduce spending level and reduce the rate of growth. And I think things like comparative effectiveness, reference pricing, applying industrial engineering to make delivery more efficient, changing payment to get better incentives in place, all make perfect sense and certainly make a difference. I don't think any of that will get us anywhere near the health spending levels of other industrialized countries. And really, when you look at the difference, you look at what's driving spending in this country, it's largely technology, largely use, and not prices. Prices have not been increasing very fast. In some cases, have actually been decreasing. But if you look at our spending compared to other countries, it's almost all prices. Our prices are dramatically higher than other countries. So if we ever hope to get down to the level of Canada, France, Germany, we got to figure out some way of getting prices down, and that will be incredibly controversial and disruptive.
Yeah, but the frustration in reality is that compare our system to the Canada and some of the Asian countries I travel. Very simple. If you need some MRI, brain imaging or medical imaging, in Hamilton, in Canada, you need to wait for 6 months. But here in Boston, I can send you there next week, or just same day if urgent. So I don't complain our system that's costly, expensive, but the efficiency and the quality of care, would be much different. And also compared to France and U.S., in terms of the medication and the drug development, actually the French government, they put a ceiling on the price, and here it just go wild. You can get a pill $10,000 per one pill, which is more expensive than a diamond for hepatitis treatment here. However, since the French government, they put the ceiling on the price and the innovation dry up. But you can still see America is the #1 innovation and new drug development country that we enjoy and proud of. However, the sufferer is that the poor, I would say the underemployed or the poor population, they pay a large bill which may be shared by the government, the insurance payer.
Oh, and there are. I could talk forever about this, but there are. We all want prices to be lower, healthcare prices to be lower. We all want spending to be lower. But there are trade-offs, and we're a wealthy country, and it might be that wealthy countries want to and should spend more on things like healthcare.
Thank you very much.
Thank you. I've got yeah.
Thank you for your presentation. You seem agnostic about the cost savings with single payer. Could you comment on 3 things? Firstly, unbundle out-of-pocket costs and deal with both deductibles and copays, which I think are 2 different animals. Secondly, comment on the $800 billion administrative cost. And thirdly, can you comment on the hockey stick?
Sure. So to start with administrative costs, there's no question that a single-payer plan could dramatically reduce administrative costs, and that would produce a tremendous, one-time benefit and free up money to cover more people. Deductibles, I do think we have to get a lot smarter about cost sharing. And it's interesting, I don't have it today, but we've done some analysis looking over time at people in employer plans where out-of-pocket costs have increased quite dramatically and far outpaced worker wages, inflation, and what insurance is paying for towards medical care. But there's also been a really significant shift in the types of out-of-pocket costs that patients have. Big increases in deductibles, big increases in coinsurance, and actually decreases in co-payments. So that's left patients much more exposed to healthcare prices and rising healthcare prices through percentage coinsurance and deductibles. So I think we have to start to pay a lot more attention to what types of cost sharing patients are exposed to, what incentives those appropriate incentives those do or do not provide for reducing ineffective care as well as reducing effective care. And potentially moving towards a system, as we've done in the ACA, where they're scaled by income. I personally don't think there's anything wrong with a higher income person, with a high deductible plan because they have the assets to deal with that. Low middle income people have very little assets to cover an emergency, and deductible, especially a big deductible, is a huge problem. And a single payer, I mean, I think it's entirely possible that a single payer plan could reduce spending even beyond administrative costs, but I'm not sure it's a certainty. I don't think we've seen how Medicare plays out and debates over Medicare payment levels at the federal level. But I think it's hard to extrapolate from that to what a single payer plan, where literally there's a debate every year about how the system is financed and how much we can afford versus how much doctors, hospitals, and drug companies are getting paid.
With that, we have to move out as there's a class coming in for 3 minutes. Sorry,